Hello. Good morning in Asia. Good evening to us on the other side of the world. Wherever you are, welcome to the first installment of the UPLB Chemical Society's webinar series. This webinar was open to the public outside of ChemSoc, outside of UPLB, so we welcome everyone. Special shout out to groups from Olongapo City. We have teachers and even military personnel. I am Leilani Mercado, and I will be the moderator this morning. If there is a silver lining to the pandemic, one is the getting together virtually of the alumni members of ChemSoc on Saturday evenings, and this gave birth to the periodic table project, which we now call the Elementa project. Elementa has turned into a springboard of ChemSoc alumni's other activities that will support the Institute of Chemistry, its students, and the UPLB community in general. This is just the beginning. To kickstart this webinar series, what is more apt than to discuss the topic that started it all? COVID-19. It has been more than a year since COVID-19 shocked the world. While we all lament the suffering of COVID-19 patients, their families and loved ones, we as chemists and scientists cannot help but be in awe of the behavior of the coronavirus. In fact, we continue to be curious about the next steps that the science community is taking to conquer the virus and in due time finally control COVID-19. Speaking of the next steps, while we all have been sick of hearing the new normal and following protocols, the hot new topic is the COVID-19 vaccine. This brings us to our first speaker today, Dr. Laureano Bondoc Jr., who will enlighten us on this subject matter, the biochemistry of COVID-19 and related vaccines. Dr. Jojo Bondoc got his Bachelor of Science in Chemistry and Master of Science in Agricultural Chemistry degrees from UPLB. He was an active ChemSoc member as a student, and he also taught for several semesters at the Institute of Chemistry before he left for the United States for graduate school. That's where he earned his PhD in Physical Chemistry and Biochemistry from the University of Alabama. He stayed on in the US and has since spent the last 28 years in the biotech industry working on human and veterinary medicine. He is currently a project manager at Amgen Aditi Consulting and is now based in Hagerstown, Maryland. Now, we would like to remind all the attendees that questions will be entertained after our two speakers are done. Meanwhile, you may type your questions in the question box. So without further ado, please welcome our first speaker, Dr. Jojo Bondoc.
Hello, and thank you to everyone tuning into this webinar. Hello to ChemSoc sis and brads, colleagues at and from the Institute of Chemistry at UP Los Baños. Hello to family and friends. And of course, hello to our other kababayan tuning in. I would like to extend special thanks to the group of ChemSoc Global alumni behind this Elementa project, and also the co-sponsor through Dr. Mavic Laksamana, the Institute of Chemistry, for this presentation. It is my pleasure to present this presentation on COVID-19, biochemistry, and getting back to normal. So my approach would be to invoke the concepts and principles in biochemistry to understand more about COVID-19, more about our human immune system, about natural immunity and helping it through diagnostics, therapeutics, and vaccines, and cap it off with herd immunity in order to get back to normal. Of course, the pandemic was declared in March 11 for this infectious version of the SARS-CoV-2. And so far, there have been 89 million cases in the world with 1.9 million deaths. And it costs the US approximately $16 trillion. And of course, there's also the question on new variants coming out, not only the UK and South African, but there's also recently some lately. So the COVID virus, it's a envelope virus, and it on its outside, this is probably the most famous spike protein for this virus. And it's one of 27 total proteins. Inside the virus, you have a nucleoprotein and an RNA. And so there's no DNA for this virus. So it has a diameter of 100 nanometers. So technically, it's a nanoparticle. In the next slide, I'm showing you COVID-19, and I also included IgG, and the cell that usually takes care of this kinds of virus, which is a macrophage, and it's a huge 20 micron or 20,000 nanometer. To give a better feel of this size difference, if the COVID-19 virus is the size of a man, the size of the macrophage is a 79-story building. So the virus is really very small. For this slide, I just want to emphasize that COVID-19, which is a coronavirus, belongs only to one of 7 classes of viruses. And I'm sorry, I've also included here the flu virus, which actually belongs to a separate class of virus. So what does the virus target? So I'm showing you here the alveolus. This is like the tiny sac at the end of the bronchial tubes in the lungs. And next to it is a capillary. And what's showing here is for the deoxygenated red blood cell passing through, it releases the CO2 to the alveolus, and the oxygen is taken in to oxygenate the red blood cells, and the oxygenated cells go back into circulation. In the inside lining of those cells is what we call the pneumocyte cells, and it's those cells that actually are being targeted by the virus. So this slide just shows you the infectious cycle, wherein if you have the virus just approaching the cell, the S protein on the virus actually binds to an ACE2 receptor on the cell. And once that happens, there's a separate protein, a protease, that cleaves the S protein, leading to fusion and then internalization of the virus. So to make a long story short on what's happening inside, there's encoding, transcription, translation, and then assembly, and then eventually exit of the numerous progeny viruses. And before leaving the slide, I just want to mention, with regards to the infectious UK and South African variant strains, there's a possible rationale or explanation that with this hypothesis that it's possible that those new strains increased in infectivity because there could be faster binding of the virus, faster cutting, faster fusion, or faster internalization, a combination of this or even all of the above. So let's check out the human immune system. So the system is actually so complicated and so sophisticated, there's gotta be a way of handling this type of virus. So showing you here, the human immune system actually consists of 3 lines of defense: physical, chemical barrier, the innate, and also the adaptive. The first line of defense, which is the physical one, includes the skin, the bronchial mucosa, the GI tract, and also the reproductive tract. For each person, if these tissues, if the physical area of these tissues are laid out end to end, the area would cover approximately 400 square meters. 400 square meters. That's like 2 tennis courts or maybe 2/3 of a basketball court. So this is really a large perimeter for the immune system to defend. Going to the innate system, so if the microbe passes the first line of defense, the second one kicks in. This is a faster response, minutes and hours. It has danger signals. And it involves inflammation and fever. So by observing that, it means that there's a battle going on. There's phagocytes involved. I'm not going to mention this until it needed to. And those phagocytes have receptors that can recognize molecular patterns. And then the last one is the complement system, which can create like holes in those microbes. So when the virus goes through here, it has the adaptive, it meets the third line of defense, which is the adaptive immunity. Although this takes days or weeks to develop, the responses are actually very strong. And there are two components to this third line of defense. There's the humoral, which has antibodies, B cells, and plasma cells. And then there's also a cell-mediated part, which involves T cells and macrophages. So for the rest of the talk, I'll be focusing mainly on the adaptive part of the immune system. So how does it do it? So on the humoral side, you have a neutralizing IgG. So this is like a review to probably most of the one listening. You have the IgG as your typical Y-shaped molecule. Well, it has an antigen binding fragment, 2 of them. And this is kind of anchored on a constant fragment. So the IgG is 80% of the total immune globulins in the system. And it has a relatively long half-life, 23 days. So it could be in the system for maybe up to 2 months. And it enhances phagocytosis and neutralizes toxins and viruses. So how does that do it? So if you have the COVID virus, you have this IgG attaching or binding to the spike protein. And that's, so the antigen is the spike protein, the epitope is part of the spike, and the FAB is interacting with the spike protein. And that then the FC region is recognized by a macrophage with a receptor. And when this happens, when things lock up, the macrophage is going to be ready to phagocytose or ingest. And this is what happens essentially. It's essentially eaten up. The macrophage usually eats up the virus and it's internalized. And what happens is there's enzymes or some small chemicals that degrade the virus and the degraded virus and the macrophage actually recycles some of the remaining things. So the question is, for that important neutralizing IgG, how does the immune system generate it? So it starts with this spike protein antigen. And this is degraded into small pieces, maybe 20 amino acid long peptides. A cell, a different special cell picks it up, puts it, and it's presented. I'm showing here one example of a presentation to a B cell. And it's possible there could be 500 more interactions because there are many peptides generated. And this B cell is actually activated and there's proliferation, meaning it increases in number and then it matures, resulting in actually many clones of IgG secreting B cells. And each clone actually secretes a unique IgG. What happens next is some of the IgG becomes memory cells. And if there's an attack that has to be addressed, the B cells are converted to plasma cells. And this is pretty amazing. Each plasma cell can produce like 2,000 IgG molecules per second. 2,000 per second. So the IgG generated, to summarize, comes from the spike protein. And I have to add one thing before I leave this. With regards to the question on the variant strains that are generated, and probably there's going to be more in the future, it's possible that if the immune system is already primed, all these other variant strains can be addressed with these other clones. So what about the cell-mediated part of the adaptive system? And the star here is the activated CTL, or the cytotoxic T lymphocyte. So what happens is if there's a virus-infected pneumocyte cell, that cell can actually, if there's some spike protein that is degraded and it's actually presented outside, the CTL recognizes that, and the CTL would zap it figuratively. Actually, it makes the virus-infected cell commit suicide, or what we call apoptosis. So with suicide, the any sub-virus particles inside the cell just stay there, and the killed cell just collapses. And who takes care of cleaning up? We have our macrophage, which cleans up. So the macrophage, even though it's like 20 microns in diameter, it can even grow double its size in order to accommodate what it should be eating. So how is the activated CT cell generated? So there's a similarity with the humoral one, wherein it also starts with spike protein antigen. It gets cut up into small pieces, like 10 amino acid long. A presenting cell picks it up, and it's presented to a naive T cell. I'm showing you one example, but it's possible to have more times of interaction because of the amount of peptides generated. The T cell becomes activated, cytotoxic T cells, with again several clones, where each clone is recognizing like one particular fragment. After this, proliferation, and then there's a career decision where some of them become memory cells, and then the activated cytotoxic T cells that search for those infected cells. So again, the cytotoxic T cells are generated wherein you start with spike protein antigen. So since it takes time for the adaptive immunity to kick in, how do we help the immune system? I'd like to start to make sure that there's diagnostics to guide treatments. And I'm showing you that the two like common tests being run during this pandemic. And because of time, I won't be able to elaborate more on each one. Just to say that for viral testing, which is RT-qPCR, using a nasal or saliva, this is a 2-hour assay. The purpose is just to determine the presence of absence of the virus. The second assay, the antibody testing assay, using blood as a sample, is an IgM, IgG, ELISA, a 30-minute assay. And this is to determine if the person has developed adaptive immunity. On the next slide, I'm going to show you the therapeutics used in the hospital, at least for emergency use. And the purpose of the therapeutics is if a person has severe symptoms, this is just to help in reducing the effect of the viruses already there, in order for the immune system of the person to catch up and then finally get rid of this. So there are under 200 plus treatments still in development, and and of course, if you guys remember, this is the life cycle for the virus. There's a monoclonal antibody that can actually bind to the spike and then prevent the binding. And of course, it can also tag the virus, as you've seen earlier, for phagocytosis. There's a pharmaceutical called remdesivir. It's actually an antiviral that inhibits the RNA polymerase inside here. If that does that, then you minimize the amount of virus. Third, which is used for emergency use, is dexamethasone. This is a glucose corticoid, and it's an anti-inflammatory or immunosuppressant, probably primary to dial down like the cytokine storms or other danger signals, where if the immune system is already almost like in a disarray. And last but not the least, even though it's not officially used as for emergency use, the doctor still has the capability or can decide if it can still be used for treatment, because it can still function like the monoclonal antibody treatment. So this slide introducing natural immunity, and of course this can be obtained from exposure. So I have here an infected person in 3 scenarios, either from sneezing or talking or being close contact, wherein the one in close contact has no symptoms, but it's positive from the viral testing. Then you have the one with the mild symptoms, but positive, and then you have the severe symptoms. So for the first one, as time goes on, that person would still have no symptoms. And if the adaptive system would kick in, eventually there's going to be no virus, negative test on the viral, and this person is going to be considered immune, and no vaccination is needed. Sorry. For the one with the mild symptoms, maybe maintain the mild symptoms. There's no need for hospitalization. And eventually, the person would have no virus with negative tests, which means the adaptive system kicked in and the person would be immune. And again, no vaccination is needed. And for the last one, wherein there's severe symptoms, and of course, all these are carriers here, it would still maintain its severe symptoms that the person would need to go to the hospital. And that's where those treatments come in. And hopefully, the immune system can catch up and be able to eventually eliminate the virus. So for this person, that's going to be considered immune. And so no vaccination is needed. So by just from exposure, it's possible to have natural immunity, wherein for those who already eventually become immune, vaccination is not needed. And of course, as a segue, for the ones that's not exposed, which is considered non-immune, vaccination is going to be needed. So for vaccination, what are the targets? So of course, this is the familiar life cycle of the virus. You would need to have neutralizing antibodies to prevent the binding. The vaccine should also, with those neutralizing antibodies, primarily for the spike protein, could be used for tagging the virus for phagocytosis. And then, of course, as you've seen earlier, generation of the activated CTL, so that it would take care of the virus-infected cells. Which goes us to the various vaccine technologies. So right now, even though there's a few vaccines used for emergency use, there's still 300 plus vaccines under development. And for vaccine technology, the key is, again, the spike protein antigen. So as far as a technology platform, one can use an attenuated virus, wherein it's a non-replicating virus. The virus infects the cell, the translation, and then you produce, and in situ, the spike protein is produced. Another technology, and this is the Chinese vaccine, wherein they grew the virus, inactivated it chemically or by heat, and then use that as a vaccine for injection. And then that, of course, has the spike protein. So the question is, why not use the spike protein? Yes, there are companies who actually make the spike protein separately and then inject it to the patient. Another platform is the AstraZeneca, Oxford, and this is also similar to the Gamaleya Russian vaccine, wherein they actually use adenovirus vector. So the spike protein DNA is cloned in the adenovirus so that non-replicating vector infects the cell, uncoats. There's transcription, translation, making in situ the spike protein antigen. The next platform is probably the toast of the town because it's the Pfizer and the Moderna platform where you have mRNA in a liquid nanoparticle. So this nanoparticle gains entry to the cell. There's uncoding and then translation in order to again inside you make the spike protein antigen. There's also what they call a plasmid DNA vaccine, wherein plasmid DNA, which is like small circular DNA, the spike protein DNA is again cloned. The plasmid is the plasmid is the vaccine, so it enters the cell. There's transcription, translation to make the spike protein inside you. And last but not least, there's a technology called VLP or virus-like particle, wherein it's possible to engineer. So the VLP is like a protein shell for some viruses, and it's possible to engineer so that that protein would also contain a part of the spike protein. So with regards to, so even though there's different technologies out there being developed or already in use, the key here again is the spike protein antigen. So let me show you in this slide that the average development time for vaccine development is like 7 years. The record is 5 years. And this just shows you the different steps in the development process wherein you have research, manufacturing, there's toxicity studies, then there's this clinical studies, phase 1, phase 2, and phase 3. So like 100 volunteers, 30,000. And if you look at the pandemic track, even though the development time was done in 10.5 months, all the required activities needed in vaccine development are still in place. The only difference is everything is just shortened. And how is this possible? So shorter time, but the same process activities. So there are two things at the front end. The first one is there's already an upfront. So in the US, there's already an upfront payment for to the manufacturers because it's very expensive for those clinical trials, almost like $10,000 per subject. And so once they got the money, at least you're gonna be able to start the trials. The second item is even though there's a lot of volunteers needed, especially for the phase 3, and usually it takes time to recruit volunteers, but because of the urgency of the matter, there's a rapid sign up. So for, let's say it takes like months to recruit people, it's narrowed down to even weeks. And at the back end, because of the urgency again, for the ones reviewing the data, have high priority review, the hospital data review board, the vaccine review board, and of course, at the end, high priority review by the FDA, and then eventually the CDC. So in this slide, I'm just showing you the different vaccines and their components. So I'm showing you the Pfizer, Moderna, and the AstraZeneca platforms. One thing that immediately stands out is if you look at the active ingredient, of course, Pfizer and Moderna are RNA. So Pfizer uses like 30 micrograms. Moderna uses like 100 micrograms. And then for AstraZeneca, this amount of particles is approximately like 50 microgram. And I would like to emphasize that that amount is much smaller compared to, if you remember the treatments in the hospital that I mentioned earlier, it's up to like 1100 milligrams or 1 million micrograms. So you can already see that with the vaccine, for a small amount, it really goes a long way. And with the rest, for the rest of the components, you have some lipids, which is for the nanoparticle, and then buffers. The volume is almost the same. And one thing I have to note here is there's no SARS-CoV-2 in any of the vaccine platforms. The efficacy is at least 70%, and they pretty much injected IM and with 2 doses. On the next slide, which is an important one, I just want to mention that. So on the y-axis, the relative antibody level, and then on the x-axis is the days. So after the prime dose, there's an observation of IgG and IgM, and IgM is the red one. But after the second dose or the boost dose, after 7 or 14 days, there's a huge spike of IgG. And this is significant because you have to have that booster dose in order to get that. And looks like for each one of the platforms, they should be able to come up with a minimum threshold for infectivity. And finally, this is probably my bread and butter slide. So right now we are here. We're mostly non-immune individuals. And so with good hygiene, diagnostics, therapeutics, and natural immunity, we should be able to go towards herd immunity. Herd immunity essentially controlling the spread of the virus. But if we just rely on these things, it would take probably 3-4 years. So with vaccines, the point here is with vaccines, there could be rapid development immunity, so that if we just target 6 to 7%, we should be able to achieve that. And that's what actually is getting back to normal. So to summarize, with this pandemic and in this presentation, I've used biochemistry to understand more about the virus and its infectious cycle, and also about the human immune system, especially the adaptive immune system. And it's really special for, I guess, for everyone, and for technology advancement in particular, that vaccines were developed, even though it's approved for emergency use in record time without any shortcuts. And as I mentioned in my previous slide, with good hygiene, diagnostic treatments, and natural immunity, vaccination would fast track towards herd immunity, getting us back to normal. And with that, maraming salamat po, and I would entertain questions in the Q&A.
Thank you very much, Jojo. So we heard a lot of information. We now have a lot of questions. For now, please type your questions in the chat box, and Jojo will answer the questions, okay, after our second speaker. So let me introduce our next speaker. He is a part of the Philippines' key team for frontliners in the fight against COVID-19. Dr. Loy Solomon Garcia has come a long way from his UPLB days. He finished his Bachelor of Science in Food Technology from UPLB in 1985, and he was also an active member of ChemSoc. He then went to medical school and he specialized in surgery, and then he joined the Philippine National Police, where he served at various roles. He was the chief of the preventive medicine section, and he was the leader of the chemical, biological, radiological, nuclear, and explosives team during major public events like the ASEAN Summit and the Papal visit. And he is a COVID-19 response and planning consultant. This year, he came out of retirement and now serves as the health consultant of the Office of the Chief at the PNP. So from emergency preparedness to response task force, he has seen all the action even before this pandemic. Today, he is here to share with us what's next for the general population after 1 year of COVID-19? What normal should we be expecting in the time of this new normal? Everyone, please welcome Dr. Loy Garcia.
Good buddy, every day. I'm here to present to you my presentation. It's been 1 year, and in fact, it has been start from been exactly 366 days ago when the WHO started or announced that there is a new virus. This is like sort of many Forrest Gump like coincidences, because it's 366 days and many things have happened since then. And now we have changed our lives, our economy, and society forever. And we started picking up from where Dr. Bondoc summarized. My goal is to present in practical terms as we apply the scientific evidence and knowledge in our daily lives and clinical applications. What is COVID-19? This is a WHO definition. COVID-19 is a disease caused by the new coronavirus called SARS-CoV-2. WHO first learned of this new virus on December 31, 2019, following a report of a cluster of cases of viral pneumonia, quote unquote, in Wuhan, People's Republic of China. A day later, I picked up this info and told my colleagues in the Philippine National Police who were preparing for the translation. That's another of the coincidences today, because it's the celebration of Black Nazarene. We already found out that there is this virus, and we were afraid that it might go out of hand during the time. And what are the symptoms of COVID-19? The most common symptoms that you must remember is that 88% of fever, dry cough, and fatigue. Remember dry cough, not the ones that you have productive cough. And other symptoms are headache, loss of smell, nasal congestion, sore throat. Sometimes there's sputum, shortness of breath, pain, muscles or joints. You have chilling, nausea and vomiting, quite rare, and diarrhea, which may mean anything from 4 to 30%. But in severe disease, you might have difficulty in walking, confusion, bluish face or lips, coughing up of blood, persistent chest pain, decrease in white blood cells if you took a CBC. And worst things are kidney failure. Now, start with data first. The dirtiest part of any office or even in your rooms is actually the toilet or the washroom. Now, in the toilet, flushing aerosolizes the droplets. And then it goes to the surfaces, door handles, and faucets and doors. And when you cough, you have 3,000 droplets moving at 80 kilometers per hour, and you have 0.5 to 0.63 seconds in less than 2 meters. If you are that close, can you avoid that? Person sneezing, 30,000 droplets moving at 320 kilometers per hour or 88 meters per second. So you have only 0.1 second to avoid that. Just like a airplane coming at you. Normal breathing, you have 50 to 5,000 droplets depending on your the loudness or the amount of talking you do. And in the environment, it will stay for 3 hours. Now, downwind, COVID-19 moves in a conical pattern And if you are within that zone 1, which is within 1 to 2 meters or even more, if there is depending upon the air circulation, it will break up in about depends upon the air or even the wind conditions. So that within 2 to 3 hours, if you are inside that zone, you will be infected, and it will start to break up further and further. Now, to summarize what Dr. Bondoc, this slide shows it that the attachment happens in the ACE receptors of our cells, and then it uncoats and replicates and releases the virus, and then that's when the problem starts. This is what we knew last year, and since then we have known many things. Before, we only knew that it was in the lungs, in the heart and vessels, and we were trying to get more information on the other organs, the brain, the eyes, nose, liver, kidneys, and intestines. Now, we have later learned that this infection causes cell damages and inflammation in the body when it enters the olfactory bulb. It affects the brain through interaction of the neurons, which control the sense of smell and the reactions inside the nasal membrane. And then, furthermore, that SARS could do a lot of damage, particularly through the endothelial damage of the cells, affecting directly your kidneys. The hypovolemia can also contribute to that damage to the kidneys as well. The cytokine storm, which is a byproduct of the reactions of the monocytes and the macrophages, and it causes endothelial dysfunction, which also affects the kidneys. The pneumonia causing acute respiratory distress or respiratory distress syndrome, which further insults the kidney. The hypercoagulability that happens, it causes endothelial damage and heart problems, venous congestion, and that is why people who are in severe COVID needs to be dialyzed. This is the mechanism of how acute coronary syndrome develops or heart attacks. The SARS-CoV virus affects the endothelial cells and eventually affects the coronary arteries. That viral invasion causes inflammation, the T-cell mediation, the macrophages was previously described, produces a cytokine storm, and then it affects our platelets and the coagulation system. There is plaque instability and rupture, and therefore there is clogging of the vessels, which causes the coronary syndrome or the heart attacks. And this is a mechanism seen in children called what do you call this? Sorry. Sorry for the immune system inflammatory syndrome in children, which causes renal dysfunctions, and these are the interventions, kinds of dialysis that is required. This is a very rare occurrence in children, so that the news saying that children are actually more protected. Well, we should be cautious about that. What is the risk of getting infected? It really depends on the viral load and the time of exposure, and it's an exponential. Now, with regards to your antibodies, present antibodies, even if you have enough, or you say because you have vaccination, uh, if you inhale too much viruses, your body can only respond so much. That means you still have to protect yourselves during this pandemic, because your antibodies may run out or run out of time. And that is dependent on the viral load and the time of exposure. And some notes, the study, this is an or study. The viral load in one droplet contains at least one virion, and that it can range from 7 million to 2.35 billion virions per milliliter of droplets. And what is the infective dose of COVID-19? It is assumed to be 1,000 virions. So that means if you get 1 milliliter of droplets, you might, and you will surely be infected, because you only need to have 1,000 virions to enter your body to get infected. I will now introduce to you the concept of hierarchy of controls, and this has been the armamentarium that we're using. We're not only what we do in when you are protecting yourselves. It's because of this hierarchy of controls, and this was being touted by the National Institute for Occupational Safety and Health. It says here that the least effective way of controlling the virus is by wearing PPEs. That means you're wearing a mask and your gowns. The next is administrative or behavioral controls. The most effective right now is engineering controls, because substitution, which means putting another hazard, replace the hazard, that means another virus that will eat the virus. That's impossible at the moment. And the elimination, or physically removing the hazards, well, we have started that by using vaccines, and let's see what will happen in the future. Hopefully, we can eliminate this virus forever. Now, personal protective equipment is required during the outbreak will be based on the risk of your infection with SARS-CoV, and that depends on your work and job. Workers should work within 6 feet of patients or people known to be or suspected of being infected, and those who are performing aerosol generating procedures, and they need higher protection using respirators. And what are respirators? N95 and other masks. I have to remind you that there is a sequence for donning and doffing. Donning is wearing your PPEs, and doffing is removing. And that you need to doff and don in the proper order. The thing that you should do is, you must remember there are only 2 rules there. What you wore first should be the last one removed. First in, last out. And second, those on the outside of your clothing should never touch the inside, and that the inside of your clothing should not be contaminated by the external part of your PPE. So just remember, first in, last out, and out is out, inside is inside, outside is outside. Okay. Administrative control. What is administrative control? It is what we actually do. We require action by the worker or the employer or even at the home. Typically, administrative controls are changes in work policy or procedures to reduce or minimize exposure to a hazard. And we have already done that. We want people who are sick to stay at home or work at home, or you minimize contact among workers, clients, and customers by replacing face-to-face meetings with virtual communications, just like we are doing right now, face, Zoom, etc., etc., social media, and implementing telework if feasible. And that is you have to establish alternate days or shifting changes, non-essential travel, that's why you have travel bans. And did you have communications plans or forum workers' concerns and providing up-to-date education, just like what we're doing right now, and training on risk factors and protective behaviors. For example, how to cough and to take care of your personal protective equipment. These are just as an example of an behavioral control or admin control, social distancing posters. And this is another form of behavioral admin control, what you will do inside your homes before you leave the house, on the way to work, on the transportation, and entering the workplace, inside the workplace, and then going back. You must maintain the minimum health standards at all times to prevent you from getting infected. Engineering control. This is my favorite part. Engineering controls are involving isolating employees or people from work hazards and in workplaces where they are appropriate without relying on behavior and can be the most effective solution to implement. And examples are what we're doing right now. We have plastic or glass sneeze guards, physical barriers, or drive-throughs, and then specialized negative pressure ventilations in some settings, and improving the ventilation in your homes and workplaces. So now I'll introduce to you the concept of air changes per hour, which is the number of air changes in a particular interior or rooms. And higher values corresponds to better ventilation. And what is its equation? First, you have to take the floor area of your house or your facility, and then take the floor to ceiling measurement. That's why when you're talking about the amount of air inside your room, inside the room or your house, you must take the floor area, multiply it by the ceiling, and then you get the volume, and that is the amount of air inside. And what are these air changes? You have to replace that air from time to time. And this is just a big chart showing, for example, in an auditorium full of people, you have to have 14 changes per hour. Or in your houses or your rooms, business offices, typically it should change from 6 to 8 times per hour. Now, what is the importance of air changes per hour? Because you can clean up the air faster if you have a higher air change per hour rate. For example, your ACH number is 15, then you have 18 minutes per you can remove the air and refresh it right away. Whereas if you have only two air changes per hour, it will take about at least 2 hours. That is to prevent the transmission of tuberculosis. And this is the data we still don't have for COVID-19 yet. An example of poor air ventilation and circulation. This happened in China during the early days. A woman who was infected for COVID-19 on the way to the hospital, She was seated in the middle, and it was an air-conditioned bus, and there was no proper exhaust. Everybody were not wearing masks yet, and 23 were infected, regardless of where they sat. It's because the air conditioning and the ventilation in the bus was very poor. Another case in a banquet in China was already COVID positive, and in fact, he was admitted after the banquet that night and was able to infect people in the adjacent tables because the air conditioning. They were seated. They were seated in the direct path of the air conditioned vents. People on the back of the patient were infected, along with the people that in the same dining table. But what is very significant is that the people who were near to the air conditioning vents were also infected because the air condition just recirculates the virus around the room, and that even if you are um, um, downwind or upwind, you will still be infected. This is a case in South Korea, which is an exception to the rule that 6 feet in 30 minutes you will be infected, or less than 6 feet away from a patient, and 30 minutes exposure is the minimum time. This one, within 5 minutes, people who were seated in this cafe, more than 15 feet actually, were infected. And it's because the air conditioning vents were on the ceiling, and that there was no proper exhaust. It's very dangerous to eat in restaurants because the ventilation and the exhaust, and you're eating without PPEs. Your mouth is open, your nose are open. How can you eat with your mask on? Anyway, it says here that rule in restaurants, you may be infected even if you are far away and in a shorter time. So therefore, what you should do is that stay away from the air conditioning vents. If possible, the restaurant should have open windows. The best thing is just take out the food and eat outside. Standards, social distancing is a must. Talk about enthalpy. Enthalpy for chemists, of course, maybe you recall your physical chemistry, but along with ventilation, temperature and humidity are also factors. And that that enthalpy is the transfer of energy, whether it's internal but external, and that all reactions, especially binding of proteins, involves enthalpy. And what do I mean by that? You need to have energy changes so that compounds will react. So therefore, why do we have fever sometimes? Or why is heat generated? It's because reactions require enthalpy. And there are studies on viruses trying to determine what are the ambient or where transmission and reactions may be minimized. Of course, we cannot uh, survive in extreme temperatures, especially approaching 60 degrees Celsius and above. So I will just make it easy for you. According to the initial studies, the enthalpy or the this amount or the optimum temperatures where the viral transmission and hopefully the binding and reactions are minimized, the temperature ranges from 20 to 60 degrees, 26 degrees Celsius, or 68 to 79 degrees Fahrenheit. Is it comfortable? I believe so. 20 to 26 degrees is very livable. If you are in the office at temperatures 30 to 35, not only it is more transmissible, but also uncomfortable to work with. The humidity is around 50 to 60%, which is actually well, in the Philippines, that seems to be the environmental range, provided it's not raining. Anything drier or even wetter, that means 80 to 100%. That's not good. COVID-19 has a higher energy for transmission in humidities less than 40%. And how to compute the number of persons that you should allow inside the room? Well, you have to measure the floor area and divide it by 4. The floor area is around 100 square meters in your room. Divided by 4, then you have the maximum of 25 persons. Now, you can maybe be less strict about it. You divide it by 3. So that means 100 divided by 3, that means 33 persons. So that the maximum number of people inside your room is about 25 to 33 in a 100 square meter room. Now, if you have a 20 square meter room, divided as well as 4 by 4 or by 3. And that means you can have at least 3 to 5 persons. I'm sorry for the I'm sorry it me naging unstable yata yung aking but I will return again. Share. I had a problem with our internet. It became unstable. Current slide. I'm sorry for the glitch. Now let's talk about boosting your health. Is it okay now? Okay. Can
Yes,
you hear me?
there's
Can you
slides
see?
now.
Yes,
for
yes.
Garcia.
Sorry about that. Boosting your immune system and overall health. Now, what is needed really is to consider this. Grow, go, and glow. This is all you need. What do you mean by grow? Grow means you eat a lot of proteins from meat and vegetable proteins. Go means carbohydrates. That means rice, bread, and glow are vitamins and minerals from fruits and vegetables. And I'm point. And these are the foods that are the sources of vitamins and minerals that are considered essential to protect or to boost your immunity. Zinc from lean meats, whole grains, beans, seeds, and nuts. That is important for healing. Vitamin C, which is needed for production of collagen and proteins, which constitutes as the building blocks of those antibodies. Vitamin C from fruits like oranges, citrus fruits, broccoli. Iron from green leafy vegetables. Vitamin E from nuts and seeds, wheat germ, leafy vegetables. Vitamin A from yellow vegetables, carrots, squash, bell pepper. And vitamin B6 from meat, chickpeas, fish products. That's it. You don't need expensive supplements. You just eat a balanced diet and they look delicious too, right? So no need. You just eat a balanced diet. Do not diet too much because if you starve yourself, you will risk getting be infected. But don't overdo it, of course. Now, I'd like to talk about mental health because everybody is affected, and that when you feel down, you must try to interact or talk to your loved ones and to your friends. Share what you're feeling. There are so many people who died, committed suicide, and I've witnessed also stress-induced depression and homicides. I'm sorry to talk about it, but I will. And sometimes it affects me also. It's okay not to be okay. Sometimes talking to friends and loved ones is not enough. You might need psychiatric or psychological help them and refer them to experts. Optimistic survive. And those who have negative thoughts sometimes have complications and some die. We have already seen what.
I think we are having problems with Lois' internet. Um, we can uh, we can address some of the questions. Is Jojo? Jojo, can you get on?
You said questions? Go ahead.
Okay. There's one question here. Is there any one vaccine platform that is most effective?
Actually, the answer to that is all of them are, because it each vaccine goes to rigorous testing, especially even in so many people. So if it comes out that it's good and it's efficacious, then it's a good vaccine. I don't think there's, I mean, from the vaccine point of view, as long as it works, there's no, and if there's anything that would probably be a comparator, other people would argue, is if you look at the side effects, maybe there's ones which are more, ones which are less, but again, it also depends on the person. So I guess the final answer is all the vaccines that are developed that pass all those tests from the regulatory agencies should be good.
Okay, thank you. There's another question specifically for you.
Oh.
It says that if we develop natural immunity from exposure and do not need vaccination, what about reinfection with COVID? Can we get reinfected?
Yes, you can get reinfected, but since the system is already adjusted or has those adapted immunity, it would serve as, it can be thought of as a booster shot. And if that's the case, then actually the immune response, even for future coronavirus attacks, would be even more intense.
Now, one of the members of the audience said that he read about Pfizer clinical trials that people who have recovered from COVID are still encouraged to get vaccinated. Are there data or studies on how long natural immunity against COVID-19 lasts? How long does it last?
So
Do
the
we have
answer,
data about that?
yes. So again, this is a new virus, infectious one. So people are learning. So in the next months or next months, there's going to be studies answering that kind of question. But if you understand, or for immunologists, uh, we, I guess the first thing we have to recognize that the human body is actually the hero, and it's actually evolved a sophisticated immune system that that it just improves with time. So for people who have recovered, yes, as I mentioned in my talk, the adaptive immunity has already kicked in. So any either future, I guess I can also answer any future reinfections, or if you take the vaccine, it's only just to improve the immune system. So
And we can
that should be
go,
good.
okay. We can go further. What about the current vaccines and their effectivity to the variants? Are they effective?
So in theory they are, and of course there have to be data generated for that case. And that's if I go back to my talk where I mentioned that it's not only one IgG that is generated. So there's actually a lot of clones. It's not only the IgG, the plasma, the B cells, but also the T cells have also a lot of clones. And since the spike protein is the key protein for infection, and then the protein has so many epitopes, the immune system, I think the immunologists have calculated that the immune system can pretty much handle like 100 million types of epitopes based on the analysis of the genetics of the gene. So yeah, the variants can be the variants will be addressed. I think I should also mention, which I did not mention in the talk, is so when these clones are developed, what I did not mention in the talk is there's also a constant iteration of improving the binding of like the IgGs to the target microbe. So what happens is the ones that are screened out, which don't bind long, they just die. But the ones that stay and become like memory B cells, they're actually the strongest the strongest binders to the target protein.
So if vaccination will really help, why are there people against vaccination?
So that's a good question, because it's probably stemming from experience from other vaccines. And as you know, there are viral vaccines, there are bacterial vaccines. And for bacterial vaccines, sometimes they have those adjuvants, like aluminum adjuvants, which causes like side effects. So what people would think is, oh, we have this experience back in those other vaccines, but that's actually unfair. Because if you think about it, for each virus, infectious virus, or for each infectious bacterium, there has to be a like unique vaccine that's actually made for that particular organism. So it's again, I would also add lack of education, wherein scientists should actually come out and say this kind of things, like what we're actually doing right now. Is this because there's so many things happening in immunology, and actually it has come full circle, wherein of course people in the vaccine field are interested in vaccines, but it's also and they want to elicit what the antibodies. If you look at the therapeutic part, the proteins, they don't want any antibodies against their therapeutics. But now it has come full circle that there's a recognition that there has to be a consideration of what is actually being resolved.
Loy, are you on?
Yes, natigil. Sorry for the internet. Ano, it's not my problem. Really. Dito lang sa amin ko kasi. Okay, so ano ito? Should I finish my presentation or something like that? Anyway, talking about uh, vaccines now. Um, Already, Dr. Bondoc summarized and in detail discussed about vaccines. Now I'm talking about. I will now talk about certain things not covered by Jojo, and that these are a summary. Pfizer and Moderna are mRNA based, and they have been proven to have 95% or so efficacy. And we are seeing reports that it seems to be okay. And the very first doses have been given. The problem with why Pfizer and Moderna has not been here in the Philippines right now, it's because of logistics. First of all, of course, they rolled it out first in the United States. It's because logically, the United States and Europe suffering the worst, much worse than the Philippines. So therefore, they should have first dibs on this vaccine, and that we may expect that these vaccines, Pfizer and Moderna, will be coming into the Philippines probably in the third quarter, earliest July. Now, and then we still have to work out the training and supply logistics because Pfizer and Moderna requires very low temperatures, minus 70 degrees for Pfizer for storage. Moderna around 19 to 20, minus 19 to 20 degrees. Now, AstraZeneca and Sinovac and Sinopharm from China. AstraZeneca has a much higher storage. It can be used can be stored in ordinary freezers, I think. Sinovac as well and Sinopharm. So that's why even if those vaccines are expensive, it might be more practical for us to use. And sometimes a less efficacious vaccine might work also under certain conditions rather than pushing for the more efficacious, because sometimes there are issues in logistics and storage. And of course, the training of personnel who will be implementing those. Sometimes refrigeration in the remote places, maybe the Chinese or the AstraZeneca will be more practical. That's what I mean. And do not cross vaccines because, as you can see, they have different mechanisms of action. So don't use, if you have a first dose of Pfizer, your next dose will be from Moderna, and do not interchange. Or if you use Sinovac, you must finish it with Sinovac, etc., etc. I'm not endorsing any particular brand, but first things first, I'm very clear, do not interchange vaccines. Now, autoimmune diseases, these are the things that we are monitoring. That's why we have to be cautious. And what are those diseases that we observe in COVID-19? Immune thrombocytopenic purpura. That it means your immune system is affecting your platelet function. Guillain-Barré is a neurologic disease, weakening of some of the muscles and the neurons. Another syndrome is Müller-Fisher, very different. And this whole gamut of diseases and antiphospholipid antibodies and thrombosis, pulmonary embolism and strokes. These are not diseases directly related to COVID-19, but nevertheless, because of COVID-19, this has been observed to have occurred. Kawasaki disease, and Kawasaki-like shock syndrome in children were also observed, very rare. Why? Because the production of spike proteins and spike proteins of those viruses, COVID-19 in particular, also other coronavirus, there is a so-called molecular mimicry. Because the polypeptides produced by these viruses, and these are listed, can mimic some of those polypeptides that are occurring naturally or being produced in the body. And these are the tabulations of those molecules. What I'm saying is that we have to be cautious and be very observant. It's not totally safe, but we hope that the vaccine will work against coronavirus, but be cautious and be aware that sometimes molecular mimicry happens because those spike proteins and those mRNAs can produce or mimic other polypeptides that are causing some of the diseases that I mentioned previously. I guess that was my last presentation. If you have any questions, thank you very much. And I'm sorry for the glitch that happened earlier. Stay safe.
Thank you, Lloyd, for the very enlightening presentation. Now we invite back Jojo so that we can address questions from the audience. But Jojo answered a lot of questions, so these are for you, Lloyd. Okay. Here's
Yes,
one question. Any suggestions on how to handle food and produce, both from the public market and groceries, into the house?
First of all, it's on the packaging. Packaging should be clean, of course, internally and externally. And if you receive packages of those vegetables, make sure they are disinfected, or the proper term is decontaminated. And the best thing to do is to use only soap and water, or if you want to use alcohol as spray, it might contaminate your food. So that's why all those foods, after removing the package, you must wash them appropriately. And they should not be, showing any signs of contamination, that they're dirty. Just wash them with soap and water. That will be enough for fruits and vegetables. And if they are needed to be cooked, do so, please. For example, meats, pork should be thoroughly cooked, as well as chicken. Heat can definitely destroy viruses. But while preparing food, you must be clean. And it's not only COVID-19 that you should be worried about. How about gastrointestinal diseases and also parasites? So what you regularly do to check your food to be safe for your consumption, you must take a little extra effort to decontaminate. That's the proper term, decontaminate. Decontaminate is removing the hazardous material through safe materials like water and soap.
Here's one more for you, Lloyd. We are mandated at the university labs to be thorough with wiping down touched surfaces like door handles, tables, keyboards, shared instruments. Okay? What's the current understanding of infectivity routes via contaminated surfaces? Are meticulous wipe downs effective or just a waste of time and effort in the grand scheme of the infective route?
First of all, you must remember that some materials, the virus can exist for days. For example, wood, paper. Some materials like copper, hours, still about 1 day. Now, regardless, if you think that the material is steel or concrete, you must practice biosafety every time. Doing wipe downs is good. Clean up, clean up your workplace because you never know uh, how much virus is there. How could you be so sure? Because somebody before you might have touched that and was careless um, about cleaning up, and that was the case in so many uh, so many uh, so many offices, schools, and workplaces. They forgot to clean up, so that's why you have to continue doing that. It's
Thank
extraordinary, yes, it's really extraordinary at this time. We cannot be so sure during this crisis.
Okay, this is for you, Jojo. How will you know if we need to be vaccinated when in fact you are not aware if you became asymptomatic?
That's a very good question. Uh, as I guess I mentioned in my talk about the two tests, the one viral and the other one is for antibody testing. So by actually doing that antibody testing, that's one way of actually knowing if you have antibodies, the IgM, IgG, which are specific for the coronavirus.
Now, is it possible to see mutation on the spike protein such that the vaccines developed will no longer be effective?
So that's a good question. It'll probably take maybe several studies. So because it's a hard question to answer. And
I can,
yes, follow up.
I can help you. I've been working with emerging infectious diseases. That's why on the first question regarding what's the first question about you need to have antibodies in an ideal situation before you get vaccinated. You must get first tested for antibodies because if you have enough antibodies for COVID-19, and then they are available already, antibody testing, IgG and IgM. If you have enough, you may be protected because your previous exposure, or if you were sick before, actually is a process of getting immune if you survive. That's why it's very important to be tested before vaccination. Now, the question is, if you already have high antibodies or you have a previous illness, is it safe to have vaccinations? Well, two things. First, if a protein is injected into you and you have the right amount of antibodies, then nothing will happen to you. If you don't have any of the other uh, uh, factors that will uh, that will may cause side effects. For example, if you have too much vaccination or too much antibodies in your system, it may cause autoimmune disease, or you may have a cytokine storm. That is a possibility, although that is quite remote. So that's why you have to think. So bottom line is, if you think that you were exposed or you have been asymptomatic before, and you think that you have previous infection, please get tested for antibodies. Now, if you want to be vaccinated, and that really depends on the amount of antibodies that you have. On the second question, that if there is a mutation on the proteins, for the coronaviruses, SARS, MERS-CoV, and SARS-CoV-2, they are actually almost the same, ACE inhibitors. But we don't know yet if there are other proteins or spike proteins, specifically other than the ACE inhibitor spikes or receptors, that will be uh, the ones other spikes or viruses. That's for now. It was simply yung spike proteins was the only one identified to be the mechanism for binding. But mutation meaning another virus, is that so? Because coronavirus 2 is actually a mutation of or a variant of SARS and MERS-CoV. That's why it's another disease, not just COVID-19. So that's why that variant that is very, the UK variant or the South African variant is allegedly faster developing, more transmissible. It's because it's the same COVID-19 virus. The vaccines will work currently, and the treatment should also work. And that also goes to say that the protection, the minimum health standards that we are implementing right now will also work against those variants. But for another disease, then we might have another. And please don't pray for that. COVID-20, COVID-21, and so on and so on.
Okay, one last question. We know we have a lot of questions, this last one. Do we have data on the mutation rate of the COVID virus? And do you think we will need regular inoculations against coronavirus like we have for the flu?
So for coronavirus, actually for RNA viruses in general, where they are prone to infection, I'm sure there's actually some studies out there wherein you can actually estimate based on the errors of different like generations of the virus, you can come up with an average infection rate for each of those RNA viruses. And they don't talk much about it because the ones who generate those kind of data are the ones usually done for the infectious problematic viruses. So for the ones that are not that infectious, there's data out there, but it's not. It's probably available, but since it's not infectious, then it becomes not relevant. It's like a catch.
May I add to that? Yeah. Mutations, if you think about it, sometimes it's good and sometimes it's bad. What I mean by good is that we want this COVID-19 virus to mutate and regenerate faster if that kind of mutation leads to its being harmless. So that's why if we want to hope, or we hope that the virus will mutate, it should mutate into a harmless form. What is worse is if it mutates into a more dangerous form. Now, we don't want that to happen, but we must expect it to happen because life evolves that way. So that's why I'm saying is that eternal vigilance is the price of victory or safety. So that means we will be expecting more emerging and re-emerging diseases to happen. But because of our experience in coronavirus response, we have learned a lot. The new vaccines, especially the mRNA vaccines that came out, that's the first time they rolled it out in history in such a scale. And we are learning from that experience. So that's why if there's another virus that will come up or emerge or re-emerge, we are better in addressing them. That's it.
Okay, thank you.
So that's why there's
you.
continuing studies on that mutation.
Thank you to our speakers. Thank you, everyone. Thank you for your participation. I know there are still a lot of questions that we're not able to get through. Now, this has been a remarkable session, but if you have further questions to the organizers or you would like to get in touch with the speakers, we have this email address, elementa.chemsoc@gmail.com. Just send in any questions that you want to be answered. Now, before we close, we would like to acknowledge another ChemSoc alumna, Mr. Rey Espiritu and his team from MEDConcept Solutions Philippines, or MEDConcept, for allowing us to use his platform to broadcast this seminar and for schooling us on the technical aspect of Zoom. We cannot thank you enough, Rey, and your team from MEDConcept. I would also like to call on Mr. Rene Jucares, all the way from Brisbane, Australia, to give us a short announcement.
Hello, this is Rene from Brisbane, Australia, and I would like to thank our panel speakers, Loy and Jojo, for giving us a very enlightening webinar, and Lani for moderating everything. You handled it well, Lani. Rey, thank you for this platform. We will use it again, sad to say. You'll have to put up with us. Anyway, thank you for joining us, everyone who has joined us. This is the first ever UPLB Chemical Society Elemental Project webinar series. We hope that you have gained something from today's presentation, and our next webinar sessions will be in 2 weeks, from 2 weeks time, Saturday, the 23rd of January, and it will be mostly on career orientations. It is everyone from students, recent graduates, even professionals interested in knowing what career paths are available to them will be presented on the next part of the series. All are welcome to attend, and thank you all for your support. We are looking forward to seeing you all in the next sessions. Be safe, everyone, and have a good weekend.